So starting with Improved Medicare for All, I'm assuming that many people on this call, maybe everybody, has some familiarity with it. I like to say that this concept evolves out of a set of values. It's really the values that are the starting point that then have led to the evolution of the policy and the legislation that embodies the policy that we call Improved Medicare for All. And it's very important to include improved in this phrase because we don't want people to take away the concept that we're just talking about the current Medicare system expanded to include everybody. We're talking about the principle of a publicly administered, publicly governed, publicly financed, inclusive system like Medicare as a model, but with very significant improvements or changes. And, I think when we're talking among ourselves as people who have a fair background in health policy, we often revert to just the term single payer. And that's the term that was used up until the term Medicare for All was really popularized by Bernie Sanders in his campaigns for the presidential nomination. And then Medicare for All sort of entered the public vocabulary. So the values that we start with are that we want a healthcare system that imparts universal access, delivers high quality care to everybody, not medium quality to some and high quality to others. Everybody is a VIP in this system. And this is, the way professionals, doctors, nurses, and therapists and others approach the way we try to deal with patients, which is we try to give everybody the best care that we can according to the current standard. And so we know that in the United States, we have the capacity to deliver very high quality care. And yet we know that on average, the care that we actually end up delivering does not meet those standards. The third thing is that we want the care to be equitable. We don't want to have medical oases and then a few miles down the road, medical deserts, which exist in many of our counties and localities. So when we talk about equity, we're not just talking about equal opportunity, we're talking about making sure that those areas that need extra resources, need a reallocation of resources, receive that attention. And then finally, we're talking about affordability. So these values of universal access, quality, equitability, and affordability are then what lead us toward trying to frame a policy that could embody those characteristics in the healthcare delivery system and all of the supporting structures for healthcare delivery, like education and the relationship between healthcare and all of the other social determinants of health. And we have to understand that changing to a policy of improved Medicare for all is not a panacea. I mean, health is really our objective, not just health care. And so when we talk about health, we have to talk about the structure and the well-being of our communities, our economy, wealth inequality, and so forth. But we can address a lot of those issues much better if we reform the healthcare delivery system. that the healthcare delivery system is increasingly governed by the way it's financed. And this trend has really evolved over probably 50 years, but it's accelerated in recent years to the point where the the people that govern the financing of healthcare really have the last word in terms of how long your appointment with your doctor is going to last, whether you can be referred to specialists, where you're going to be hospitalized, how long you stay in the hospital, and on and on and on. So that the old concept that the doctor-patient relationship, or to be more modern, the nurse practitioner, the physician assistant, the professional caregivers and patient's relationship should govern healthcare decision making. This has really been challenged and put under a lot of stress because of the extent to which decisions are being made by accountants, by administrators, by people who, frankly, in most cases, don't have a license to practice medicine. Okay, so we then have a policy that we should restructure the healthcare system to be focused on a mission of delivering a service to the population. That's what. So the people that work in the delivery system are really providing a service, and that service needs to be attuned to what patients are asking for. And of course, in most cases, they're asking for the highest quality medicine delivered according to scientific standards. But they're also asking that it be delivered in a certain kind of environment, through relationships where they have the opportunity to choose their provider, to stay with that provider continuously for as long as they want, to develop a trusting relationship, to change providers if and when they decide that that's what they want to do. In addition, we want the care to be delivered under conditions where patients or clients, or whatever they happen to be called, not customers, not the product, okay, but we'll use the term patients, where they have the opportunity to have their questions answered. Because for chronic health conditions, self-management is really at least half of what goes into making a satisfied patient and a patient who's able to live with and cope with the health conditions that they have. And so that depends on the opportunity to have a conversation with your caregiver, not simply to be handed a bunch of prescriptions without the opportunity to ask questions. So this policy of a publicly governed, publicly financed system where the resources are distributed to meet the needs of the population in the most cost-effective, efficient, fiscally responsible way, and are not being pulled into profit-seeking in the delivery system. This results then in the kind of legislation that's been embodied in a number of single-payer bills in the California legislature going back to the early 2000s, and in bills in Congress, both in the House and in the Senate. The economics are that the healthcare delivery system would be financed by progressive taxation, but it should be understood that those taxes replace all of the premiums and out-of-pocket expenses, deductibles and co-payments that people are now paying. And then we're going to look, in a few minutes, we're going to take a look at the calculator, which demonstrates the fact that in the vast majority of instances, the added taxes are less than the savings to individuals, to households. And so this is one of the rare examples, I think, in economics where you can have a win-win situation, where you can actually get more for your money and spend less. And so the question really should be, when people ask us, well, how are we going to pay for this improved Medicare for All system? The answer is, we know how we're going to pay for it. The real challenge is, what are we going to do with the savings? And we're going to redirect those savings partly into better health care, but partly we're going to liberate them to use for other pressing social needs. So I want to just mention some things about the delivery system. I already touched on the fact that in the encounters that people have with the healthcare system, whether it's a doctor's appointment or a stay in the hospital or going to your dialysis center or experiencing hospice care or dealing with a mental health crisis, whatever it is that impels somebody to seek health care, that we want a delivery system where the incentives of the providers, both at the level of the provider organization, if it's a large clinic system or hospital system, and also at the level of the individual provider, the doctor, the nurse practitioner, the person that you're actually talking with, and the whole team that's involved in your care, which may include pharmacists and social workers and other forms. We don't want those people to be driven by the incentive to make money. We want them to be adequately compensated, but we want their only incentive to be that they're professionals who entered the profession with their own personal ideals, to be of service and to serve the patient that's in front of them. And so improved Medicare for All is the closest that we can conceive of coming to that kind of a system. But the current system has many perverse incentives that are using the provision of healthcare to enrich profit seekers. They may be investors, they may be shareholders, they may be administrators who are very highly paid, they may be bureaucrats, but their interest is really to extract money from the system for their own well-being. And they add, in my opinion, no value to the healthcare. So when we talk about improved Medicare for All, after we go through understanding the policy and the benefits of a system like I've described, the economics and the healthcare delivery changes as a result, we end up asking ourselves, well, why can't we do it? I mean, why can't we have a system? There's no perfect system, and this needs to be understood. Every healthcare system will constantly be challenged by the need to do better and the need to adapt to new developments in science, both biological science, but also social science, to respond to the things that we've inherited from the past that present challenges like racism, like economic inequality, wealth inequality, and so forth. So there's no perfect system, but every other developed country has a system that comes closer to the values that I've described than the US. So, you know, some people have expressed it as saying there's no perfect healthcare system, but we can easily identify the most underperforming healthcare system in the entire world relative to the capacity that it has. And that's the United States. We have the most underperforming system. And frankly, I think, you know, it's something to be highly concerned about, if not actually ashamed of. And so this is what drives the healthcare reform movement. And the League is one of many organizations that has an interest in this. But I would say that there are coalitions of labor unions, healthcare reform organizations, community-based organizations, and then my other organization beside the League is Physicians for a National Health Program, and our student affiliates, who are the voices within organized medicine, if you will, trying to advocate for what I've been describing. So let me pause at this point and see if there are questions or comments just on the question of what is improved Medicare for all, how would it work, and what are the challenges that people see. I see, I'm not going to be able to read the chat. I'm not good at multitasking. So for me to talk and read the chat is just out of the question. Let's just have people use the reaction button, raise your hand, or speak up if there's silence, and we'll have a little bit of discussion.
Hi, Hank. May I ask a question?
Yes, and who?
I'm Laura here from League
Yeah.
of Women Voters in Alameda.
Harry Chase is on.
Hank, what is the other group that you're associated in? Physicians for?
A national health program. It's PNHP, and our website is pnhp.org. We're about a 35-year-old organization that was formed by physicians, but we welcome non-physician members, so other health professionals, and then non-professional supporters.
It has ham and cheese in it.
We are dedicated to working for the transformation of our healthcare into a single payer system.
It was nice. It was not a mean.
Oh, there's Eileen Bailey Frank.
And one day I told him,
Hi, this is Ann. I'm getting a lot of feedback. Hello. Can some of you who have background noise mute yourselves? Thank you, Sheila, Gail, Margaret, Linda. And so Rosalind has her hand up.
I see Rosalind.
Yeah, hi. Hi, doctor. Thank you for this. Who would you say is your largest critic? Is it the insurance companies? Or what organizations are fighting the idea of Medicare, improved Medicare for all? Would that be insurance agencies or companies?
So that's certainly at the top of the list. I didn't really mention this, but I alluded to the fact that we're talking about a publicly financed, publicly administered system. And so because we use Medicare as a model, we're talking about a system which collects, I'm sorry, I'm muting participants where we're getting some background noise. Medicare represents an insurance system where 98% approximately of the revenue that's collected goes to pay for healthcare services, and 2% is used for administration. In the world of commercial health insurance, it is supposed to be no more than 15% that goes to administration, which includes advertising. Um, and so there's an enormous amount of what I call administrative waste in the commercial health insurance approach to paying for healthcare services. And, you know, commercial insurance companies serve a very useful role in terms of fire insurance and property liability and so forth. But in healthcare, they have come into the picture for historical reasons. The way healthcare developed in the US from the 1930s on, which is really different from the way it developed in other affluent democracies. And so, yes, we're talking about replacing commercial health insurance with a publicly run program like Medicare. Now, there's also opposition from other sort of the libertarians, for example. And, you know, we have prominent members of Congress, and we have other people who hold positions of influence in society. The libertarian position would be that they're opposed to single payer because they feel like people should purchase healthcare when they can afford it and to the extent that they can afford it. And if they can't afford it, then that's their misfortune. So they're not interested in treating healthcare as a public good. The concept of a public good is that it represents something that everybody needs, and where the fact that you need it doesn't take it away from somebody else. There's enough to go around. So the fire department, the police department, the public school system, the public libraries, the roads that we travel on, these are public goods, and they're available for everybody. You know, if you privatize them and make people pay for them, the gain would be that someone is going to make a profit. The loss would be that the rest of us are going to have to pay. And so the question really in healthcare is, what good does it do to have a profit-seeking private insurance company simply move money around, collects premiums, and pays out, you know, for the bills for healthcare services? Well, their business model inevitably has to be to collect the greatest amount of premiums that they can and to pay out the least amount for services. And so they're highly motivated to set up obstruction to paying for services, like denial of payment, pre-authorization, narrow networks, et cetera, et cetera, et cetera. So this is a long answer to your question, but absolutely, you put your finger on the leading opposition, which is private insurance companies. Now, what's happened as insurance companies have made it harder and harder for providers to collect for the services that they're billing for, the providers have had to consolidate to fight the insurance companies. And we see this especially prominently in hospital systems, where we have enormous growth and consolidation of mega organizations that are going out wherever they see an opportunity to make money, and buying up practices, building satellite clinics, amalgamating with neighboring hospitals. And so these large organizations, they would not lose under a single payer system, but it makes them nervous because they're going to come under government regulation.
Hi, baby.
So that's another, you know, opposition. And then you have people that are just conservatives who don't like the idea and distort really caricature what we're talking about when we talk about improved Medicare for all. They call it a government takeover of healthcare. And they even will go so far as to claim that it's socialized medicine. Well, it isn't socialized medicine because the hospitals and the medical practices, if they're private, they would remain private. If they're public hospitals, they would remain public. The only thing that's socialized is the bookkeeping. It's not socialized medicine, it's socialized bookkeeping. It's having a government agency like Medicare collect the revenue that then goes to be paid out in a very efficient, fiscally responsible way so that providers are compensated and can continue in practice. Okay, other questions?
Yvette,
Thank
Yeah.
you.
I have a question. I've been in this horrible system for many years, and I do think Medicare is a great idea, and I am in favor of it. However, I'm wondering, you mentioned big salaries going to administrators, and I know doctors' salaries have markedly decreased from when I first entered the system, and most doctors are now paid by the institution they work for rather than their own private practice. What will happen to salaries with this new plan?
Yeah, that's a really important question. And obviously, one of the first things when we, talk to our physician colleagues, they're very interested in understanding that. And the best answer is that in the financial models, the way the legislation has been structured, there will be no significant change in physician income, with the exception of some enormous outliers. I mean, there are physicians, the average physician who spends a lot on their education, usually leaves medical school with large debts, now on the order of several $100,000, and works long hours and has, a high level of responsibility. Their pay will remain approximately the same. If they're in a small practice, their overhead will go way down. So the practice will get to devote a lot more of the revenue to paying the people that work in the practice. Right now, for every provider in a clinic, there's about $100,000 annually of overhead just to deal with the paperwork, the billing paperwork for that provider. So I just wanted to mention that there are some subspecialties where physicians have come to, for whatever reason, expect to earn, have incomes above $500,000 a year. And so some of these are probably excessive. I mean, it's not like these people do work harder or have more skill. They just happen to be in a specialty that has evolved into higher levels of compensation. So for that very small segment, and I don't want to pick on anybody, but I could say that some of those folks are anesthesiologists, some of those folks are ophthalmologists, some of them are other surgical subspecialties. They may have their salaries pruned down toward $400,000, $500,000 a year. For the hardworking primary care doctors in pediatrics, internal medicine, family medicine, who really are the linchpin of our healthcare delivery system, they are underpaid. And so they will actually see their pay go up. This is by design, okay? So this is the way the system is designed to work. And when you factor all of that, the proportion of healthcare expenditure that goes to pay physician salaries will remain approximately the same. There'll be a little bit of redistribution within it. And the final thing I want to point out is that we've studied this in our neighbor just, not very far to the north of us, Canada, and looked at how physicians are paid in the Canadian healthcare system under single payer. And their pay is more or less similar to the pay of American physicians. It's better for primary care. Most non-primary care specialties like radiology and surgery are paid about the same. And the very highly paid outliers are paid a little bit less. So the short answer is pay will be approximately the same. Okay, any other? Maybe we should go on to Medicare. Let's see if there are any one or two more questions, and then we'll go on to Medicare privatization. I don't see any other hands or, okay, Terry.
Hi, Hank. So are we talking about just California or the whole US?
Well, we're talking about both. I mean, in principle, we should really, we need to reform the issues that are problematic in California, and the rationale for reform in California exists throughout the country. So we would prefer to have legislation in Congress and put all of the states of the country, all of the people that live in the US on the same footing.
I'm just thinking about all the states that don't even take some of the money that's available to them now to help their citizens and residents.
So you're
So
making,
how do you get them to adopt something like this when they have that libertarian mindset of pull yourself up by the bootstraps, but you don't have any boots?
right, so you're pointing to the principal challenge that we have. And I just to recapitulate, the challenge is not really to understand what's wrong with the healthcare system or to design a policy to remedy it or figure out how to pay for it. The challenge is political. And so what we need are informed voters. And the reason that we have state-based proposals for single payer is because some states, are closer to being ready to move. I mean, California, we're really in the forefront. We're not there yet, and we have enormous obstacles. I don't want anyone to think that it seems like it's just around the corner and it's going to happen. Even though we're sort of tantalized by what we see as opportunities to have a state-based single payer system. But remember, the California legislature passed single payer bills authored by Sheila Kuehl in 2006 and then again in 2008. And Governor Schwarzenegger vetoed it twice based on his characterization that this was socialized medicine, which it was. And then we haven't really risen back to that same level of success since 2008, partly because the Affordable Care Act came into the picture and became the focus of a lot of attention. And we've come to understand that the Affordable Care Act accomplished a lot of good things, but it also never really fulfilled its ultimate objective, which was to have care that would be universal, high quality, and affordable. It still falls short. So the principle, I just want to mention that the principle of a state-based program is, first of all, it's most likely, if it ever comes to pass, to work in a large state. So California and a few other states like New York and Massachusetts and some others have made some advances in the direction of state-based programs. Now, when you think about the financing of a state-based program, we, the residents of California, send a lot of money to Washington to be put under the custody of the federal government. So half of our Medi-Cal program comes from federal revenue, but that's our money. It just happens to be in the custody of the feds. And the same thing for Medicare. And then there are other federally run health programs like the Indian Health Service, like the Veterans Health System and so forth. So the concept of a state-based system is that we need the permission of the feds to move that money back into a trust fund in California. The money comes from Californians. It's simply put back into the governance of the California single payer system and combined with the other funds that maybe we'll take a look at in a moment with the calculator.
Yeah. So your strategy is really to get California going in a positive light, so that, you know, what's the saying, as California goes, so goes the nation, and maybe get some other states to do that. Is that my tracking?
Well, that's one leg of the strategy. I think that when it comes to the politics, first of all, you know, I'm just a doctor. I'm not a political scientist. So do I have any qualification for making predictions about where we're going to have the best opportunity to make headway? I don't. Okay. I'm not a fortune teller. So I believe, and I think Physicians for a National Health Program believes, that we should move along both roads.
Okay.
Wherever they both have severe obstacles, it would be better to accomplish the, you know, to put our energy and our financial contributions and so forth toward federal reform, if that seems doable. And I don't, you know, it's true that there are states where, you know, that are way behind, and where the government bodies in those states are dragging their feet. But on the other hand, sorry, my phone's going off in the background. On the other hand, even in those states, many of the voters would be in favor of. So, you know, how do we mobilize that political support? And I personally think that we should pay attention to both state-based and federal opportunities. And, you know, the other thing is that in either case, it depends upon informed voters. So the work that we're trying to do to educate our communities is sort of the same. It's like we're talking about the same thing, just in two different arenas. So
Good.
That's the way I'm approaching it.
Okay, thank you.
Now, as far as the league is concerned, I should mention that, you know, many of us in the league feel that we can conduct education because single payer is an option. When we conduct education, we can say, you know, here's the existing system. Here are some of the problems. We all recognize them. What are the options? You know, we could have a little incremental reform to improve access to behavioral health care. We could have another reform to improve, you know, bring down the cost of prescription medications and so forth. That's one option. Another option would be single payer. And then there may be other options as well. And we can conduct education on that basis. And we can do it talking about options for state reform or federal reform. The league has really decided for several years to stay away from advocacy for healthcare reform at the state or national level. That wasn't the case in the period from about 2006 or 8 up until about 2013 or 14, where the California League was part of a coalition working on state-based single payer. So, you know, this is just expanding on your question of should our thrust be at the state level or should it be at the national level? We should do education, and then we should figure out how can we get the league to engage in advocacy at both levels, I think. Other questions or comments? Well, then let's go take a few minutes to talk about Medicare privatization. So while time has passed, I mentioned about the consolidation of large organizations with financial interests in basically extracting profit from the healthcare delivery system. And what has really, alarmed people and called our attention to this in the last couple of years is the fact that under the Trump administration, the Department of Health and Human Services opened up the opportunity for financial investors and speculators, venture capitalists, to create middlemen, financial intermediaries, if you will, called direct contracting entities. The term direct contracting entity is a administrative jargon, but it simply stands for the fact that a group of venture capitalists, as an example, could apply to Health and Human Services to create a program in a geographic area and then go to the healthcare providers in that area and enroll them in this program. And remember that when we talk about healthcare providers, we're not talking about individual physicians one by one. We're talking about a clinic organization, a network. So the decision to enroll is made by the financial administrators of that network. So if we're talking about, for example, Sutter, which has become involved in this, it's not the doctors who, are working in the practice who are making this decision. It's the Sutter administrators. So what they do is they agree to become part of this direct contracting entity. And then all of the physician practices have to move their patients into this direct contracting entity. Now, I forgot to mention that we're talking about Medicare here. So if any of you, and maybe some of you have experienced this, gotten a letter saying, dear Sutter patient, or whatever your healthcare network is, your physician's practice has been moved into this direct contracting entity. And we're just letting you know not to worry about it. Nothing has changed. Okay, it's just that there's a financial intermediary that, is now in the picture. Well, what's really deceptive about this, first of all, is that patients were not given the option of whether they wanted this to happen or not. They were just informed that it had happened. And secondly, you don't have to be a genius to figure out that when a new financial intermediary comes into the picture, they're there for a reason. And the reason is that they're there to make money. Now, this was created under the Trump administration as basically a money-making opportunity for financial speculators to insert themselves between Medicare and a population of patients whose medical practice has been brought into this system. So when we found out, when we in Physicians for National Health Program found out about this, and it turned out that there are other people that monitor the Medicare system, and other organizations became aware of it, and we began to discuss it among ourselves. We found that there was nothing that was good about this, and a lot that we thought was really sinister, because if Medicare becomes privatized, then how are we going to achieve improved Medicare for all when we now have the transformation of a publicly governed system into one which is now run by private entities? I mean, we know that privatization has come into the picture in our prison system, in to some extent our highway system, into our public school system, and other public goods. And now it's coming into the field of healthcare. So when an outcry was raised about this, and people demanded an explanation from Health and Human Services, and the administration changed from Trump to Biden, and the request was for Health and Human Services to terminate this program. What unfortunately happened is that there are people inside Health and Human Services who were fans of privatization, but they were so embarrassed by the unsavory aspects of this program and the exposure and the concern of advocacy organizations that they rebranded the program without doing away with it. And so they changed the name from direct contracting entity to something that's even more a mouthful of jargon, called ACO REACH, which is an acronym that I'm not even going to bother trying to dissect, because it's the same pernicious program rebranded under another name, and they intend to continue it. And they've said, people that are, inside Health and Human Services, that their long-term plan is to bring all of Medicare into this kind of arrangement over the next decade. Now, this is the most recent and sinister manifestation of privatization, but it's caused us to take a look at the older, seemingly more benign aspect of privatization, which is Medicare Advantage. I'm going to stop at this point because I see that the time is moving on, and just open it up for questions and then take a couple of minutes to show you the calculator. Grace, you have your hand up.
Yeah, both of my parents immigrated from Taiwan, came here in their 20s. And when they retired and found Medicare and Medicare billing and healthcare billing so confusing in their 70s and 80s, they both moved back to Taiwan, where they have a single payer, publicly administered private healthcare system. That started in 1995. Do you know, I put a link in the chat box about that program, written by Uwe Reinhardt, the architect of the healthcare economist, the architect of the program. But do you see any opening for us to get something like that in California or in the US? Like, I mean, the frustration in Taiwan was just so high. People were willing to try something, anything.
Well, the Taiwan story is really interesting, and I wish we had time to talk more about it because, you know, Taiwan, the population is a little smaller than California, but sort of on the same scale. And the Taiwan model has been studied a lot by, it was actually, it was Uwe Reinhardt, but it was also Professor William Shao from Harvard, who, you know, was one of the architects of the unsuccessful Vermont single payer legislation. So Taiwan is a very instructive model in how if you start with a political consensus that you want to redesign your healthcare system to embody the values that I mentioned at the beginning, it can be done. And you know, the key difference between Taiwan and California or the US is that there was a political consensus by both leading political parties that this should be done. So
But you know, maybe in California, we do have an opening then.
well, we think, I mean, personally, I think that we have some opportunities that we need to work on a lot harder. You know, we're about to open a new session of the legislature. We have had, you know, we had a bill in the last session of the legislature, but without a, I would say, really robust popular movement representing voters to support single payer legislation. So I think we have a political situation where some of the we have some advocates for single payer in the legislature. Then we have quite a few legislators that are nervous about taking a stand on something that might be controversial. And, you know, their eyes are on what impact is that going to have on elections 2 years from now. So, you know, we have a lot of legislators that are sitting on the fence. And what's going to move them is that we need a grassroots movement. We need voters. We need people in their districts to be able to advocate for this kind of change. And would the League of Women Voters like to be a part of that? That's one of the things that we're facing. But definitely, I mean, there is a coalition. It's called Healthy California Now. You can Google it. And let me go to the calculator because Healthy California Now is one of the developers of the calculator. And I see that we may have we run out of time, Anne? Do we need to end at 1 promptly?
I would say just keep going for those who could stay on.
Yeah, sorry if I.
Yeah, while you're getting the calculator up, I just want to say that in the last 3 years, my mother-in-law had a catastrophic stroke in San Diego, and my dad had a second severe stroke in Taipei. And the difference in transparency of medical billing and just stress, financial stress on the family was just night and day, because you're focused on your parent getting well and you don't expect $1 million bill. We had $1 million hospital bill from Sharp, but then, oh, by the way, we have negotiated rates, so it's only 100,000 and your copay is only 10,000. Well, in Taiwan, the price is the price, it's all published, and we ended up paying slightly less than $10,000. Now, both parents got very good care, but the financial stress and transparency was night and day.
Well, that I think that points towards something very important about treating healthcare as a public good and having a single payer system, and that is peace of mind. I mean, how much time do we spend poring over the fine print and worrying about what's not going to be covered or how excessive the bill is going to be? People in this country don't have peace of mind when it comes to healthcare. Even if you're wealthy, you don't have it. So, you know, you're pointing out something that is of enormous social value, and I absolutely, you know, endorse
I'm
and
preaching
support.
to the choir.
Yeah.
But
Now-
after being the daughter that does the paperwork for parents, I am like completely converted.
Well, if you and a few million of your closest friends and neighbors all decide that, I mean, changing the system is up to us. It's not going to happen without our taking an active role. And you know, this is going to be one of the most challenging campaigns for social change that's occurred in many years in this country, on the scale of women's suffrage and civil rights. That's you know what it's going to take. Let me share my screen and just maybe can people see the calculator?
Yes.
Okay. And okay, and so the calculator has been developed by a small team that I've been privileged to be a part of. The lead developer is Jim Kahn, who's an emeritus professor of health policy at UCSF. And Jim has really done a lot of the math behind this calculator. And then we've had very, you know, good support from the National Union of Healthcare Workers, the Healthy California Now Coalition, and from Physicians for a National Health Program. And this is a tool that, you know, was released publicly on August 1st. It's now had about 4,000 uses. And I'll tell you in a moment what some of the interesting results are, but let's run through a calculation. So it's really designed to be quick and easy to use. And, you know, if you want to look up your records to answer some of these questions, if you have to go to your tax return and so on, you can do that. But most people have a feel for the kind of numbers that they want to put in. So, you know, this is a model that's designed to sort of answer the question from the standpoint of a concept: how would a single payer system affect my cost for healthcare? Would I have to pay more, the same, or would I end up saving money? And so we ask people, first of all, if they have Medicare. And the calculator is the same for people who don't have Medicare and do have Medicare. The only thing that changes is the instructions. So because people on Medicare need some slightly different explanation, the instruction set changes. Now, if the mic is open for somebody, maybe Anne would like to do this for the first run, and we're not going to ask you for the most private information on your annual income, but would you mind sharing with us roughly what your premium payment, well, do you have Medicare or not, Anne?
No, I don't.
All right.
Both my husband and I qualify, but we're still working.
Okay. All right. Well, that's fine. So the calculator, again, the instruction set just changed. So you don't have Medicare. did you have health insurance last year?
Yes,
All right. And was it single or family?
family.
All right. So a ballpark figure, and I have to this, the numbers that are in here are default values that represent averages for people who have no clue, or they just want to use the average for the population. But for you, Anne, and your family unit, okay, you and your husband and any other dependents, roughly what was your premium payment per month last year?
Oh dear, I'm not sure. Let's say 1,000 per month.
Yeah, let's just say for the sake of illustration, 1,000, okay? And then,
You could
Uh,
leave that number for the employer portion.
okay, so you're someone whose employer makes a contribution,
Mhm.
and that doesn't apply to everybody, but in many cases it does. So since that employer contribution represents in part your compensation, we put this number in because you're contributing not all $1,400, but we give you credit for contributing half of that employer contribution. And that number comes from the literature of people who understand employer based health plans. So the calculator is going to give you credit for half of that $1,400. Now, out-of-pocket expenses. So that's everything else. Dental bills, pharmacy charges, any other healthcare expenses, co-pays, deductibles. What would you like us to put in here?
2,000.
All right. Now, I'm not going to ask you your annual income, but this needs to go in here because what the calculator is going to do is to say, to have a single payer system in California, we have existing pots of money, and those are going to remain. So funding that comes from the federal government, funding that comes from the California Medi-Cal system, that collects taxes and so forth, that's all going to remain. What we're going to replace, though, is, and we're going to tax you, you're going to pay zero out-of-pocket premiums, deductibles, once we have the single payer system, okay? There will be no more payment from you except your tax contribution, and that's going to be based on your annual income. It's a progressive tax. So I'm just going to say, since this is a family unit, and, you know, just judging by your level of education and so on, I'm going to give you and your husband a combined income. And for the first run, I'm going to put in combined income of 100,000, whether that's representative for you or not, because we can go back and change it. And now I'm going to put in your zip code. The only importance of the zip code is that if we get to a point where we've collected 1,000 calculations from people that live in your congressional district or your state legislative district, we can then bundle that together and say, dear legislator, 1,000 people that are your constituents ran calculations, and this is, let me show you what the consequences would be. So that's why we collect the zip code data. So I'm just going to put in my zip code because it really doesn't affect the calculation. Okay, now calculate. So dollar bills are raining down. Here's the result. You now pay $22,400 a year. That's what you told me based on your annual premium and your employer contribution and your out-of-pocket expenses. Under an improved Medicare for all, where you pay nothing more than taxes, your taxes would be $2,840 a year. So this is what you could save. Now let's go back and recalculate. And I'm going to suddenly make you quite a bit more affluent. So your taxes are going to go up to $200,000 a year. So you and your spouse, partner, husband, you know, are now in a higher tax bracket. So your savings are not going to be as good, but are you still going to save money? Yeah, look at that. Let's now, when you look at the calculator, first of all, notice up here that the way to find the calculator is to go to the coalition website, Healthy California Now, and the website is healthyca.org. And then you don't have to put in Medicare for all single, you just have to put in /calculator. Or you just go to the website and the calculator is, there's a big link right there. So go to healthyca.org and find the calculator. And you can have it on your mobile device or you can have it on your computer. There's a little more explanation, and then there's a set of frequently asked questions, okay, down here that should explain a lot of the questions that, you know, we think people want more information about. And I'm just showing you what will improve Medicare for all pay for. So it'll include, you know, these things, but here are the additions: dental, hearing, and vision care, 100% of your prescription drugs and medical devices, if you have a pacemaker or you know, a prosthetic hip or whatever. Mental health and substance abuse treatment on a par with physical health conditions. All of the laboratory and imaging services, MRIs and so forth, all reproductive and abortion care, rehab, ambulances. Okay, so this is all explained in the frequently asked questions. And then the tax structure is explained in more detail. Now, in this model, for the sake of an initial run, Dr. Khan did not include long-term care. But let me just point out that we're putting out a new edition of the calculator that will include long-term care. So everybody will receive in-home health support services or institutional long-term care according to their needs, just as if they had the best private long-term care insurance, which only 10% of seniors have. And we will have a new edition of the calculator. And our preliminary results are that the vast majority of people will still end up saving money, even after we bundle long-term care into the system. If people are still interested, we could do one more run of the calculator, but maybe we don't need to. Maybe people have, you know, grasped. This is a proof of concept. The concept is that we can have a universal coverage that's very comprehensive and where almost everybody saves money. So who would not save money under the system? Well, the person who has such low income that right now they don't have any premiums. So the way the system would work is if you're truly impoverished, you will pay nothing. But if you have a modest income, and right now your healthcare expenses are very low, you may end up paying something, but it will be very affordable. And then on the other end of the spectrum, if you're ultra wealthy, you'll end up paying more than you pay now, because there's some fairness, there's some wealth distribution that's built into this system. But here are the results that we have so far. After several months, we tallied up approximately 4,000 runs of the calculator. And of interest, we wanted to know how laborious was it for people to use this. And we found that the average person spent 3 to 5 minutes doing the calculator, figuring out what to put in. And 90% of all the people who used the calculator ended up with a calculation that saved them money. And here are the average savings. For people on Medicare, it averaged $5,000. For people not on Medicare, it averaged almost $10,000. So why do people on Medicare end up saving less? Probably because their income is lower in retirement. It's shifted more toward Social Security and fixed income, and therefore their taxes are going to be less. So if we take all of the users, all 4,000 users, 90% of them save money, and the average savings were just under $7,000. So I'm going to stop the screen sharing, and Ann, I'll let you close the program.
Oh, yeah. Do we have any last minute questions here before I'll say goodbye? Thank you so much, Hank. It was just very informative. I know we could continue this conversation. Did anyone have any other, Terry? No, does anyone have any
Good program.
comments or questions? Yeah, and does anyone want to make any announcements before we go? Should we mention, Hank, we do have a state healthcare interest group. I'll do a follow-up email to all the attendees with some of the links, and we'll save the chat. Any other comments or questions or announcements?
Let me just make a final pitch that play with the calculator. There's a way to send feedback if you find problems with it, things that are confusing, something that you don't like about it and would like to see changed. We're very open to, receiving that kind of feedback. But to the extent that you think it is useful, show it to organizations, show it to people at meetings, show it to your friends and family, show it to your elected officials, and let's get the word out that we now have a tool where people can see what the actual impact would be for a healthcare system that would, be changed to meet the values that we discussed at the very start of this program. Universal, high quality, equitable, and affordable. And this is hopefully something that will help to build the popular support that will allow us to make the political changes that we need. Thank you very much.
Thank you.